what do we know about why a person would try drugs? That sounds like an after-school question, but don't give me an after-school special answer if you can, I guess.
Sure, I think broadly people try drugs for a number of reasons. So a lot of it is peer influence. So if you're talking about youth, you're thinking about what your friends are doing oftentimes. Oftentimes there's also social context or neighborhoods that people live in. So what's freely available in that particular neighborhood? So before we started, we were talking about The Wire, which is this great treatment of urban poverty and drug abuse in the United States. So a lot of it is around the resources that people have, the coping resources they have, the opportunities they have and the lack thereof.
Yeah, because we're not just talking about youth tonight, for sure.
Right,
sure.
Right. And I think with prescription drugs, what makes it such a difficult problem is that if you look at the populations we've looked at that are opiate addicts, over half of these people started initially with a prescription from their doctor or dentist to treat pain. And that includes a broad spectrum of people from 18 to 75. And so it's not just a youth problem now. You have this prescription opioid problem that runs the gamut from young people all the way to old people. And in fact, we see this problem from old people to middle-aged people to young people. And that makes it a very difficult problem, A, to diagnose and track, but also to treat, because you have to incorporate all these factors of, instead of just a young population that you're targeting, you have to think about older people that are in pain versus abuse. So,
and how our bodies react differently at different ages, I'm sure.
Right, and pain is one of the most difficult things medically. I'm not an MD, but MDs will tell you that pain is one of those things that's very personal. And there's like you said, there's a wide range of what is painful to one person may not be as painful to another. We were talking before the set again, we still
use that scale, that smiley face, frowny face scale as the best measurement we have for pain. And then, again, what makes it so difficult is, when does someone cross the line from treating pain to addiction? Because there's a number of people we talk to that say, well, I use opiates more than I should, but I do it because I need to treat my pain. I need it to feel normal. Right. Well, those people are using 20 pills a day. So is that actually treating pain, or is that actually an addiction? It's a very fine line between the two.
Yeah, sure.
So what do we, how does what we know about why help us try to come up with some way to prevent it?
Well, I think one of the big things now is better education for doctors in medical school in terms of pain management. I was at a conference last week, and someone showed a statistic that doctors receive about, on average, 7 hours of pain management training, whereas veterinarians receive 40 hours of training on pain management. And there's this...
Say that again. How many hours does a doctor get for pain management
On
training?
average, it's about 7 hours in medical school versus about 40 hours for veterinarians. Granted, it's different species, but you can see that there's... And the people we talk to, there's people that say, a large group that say, well, I was undertreated for pain, and so I went out and sought medications on my own. Right. You have this group over here that says, well, I was overtreated for pain, so I use my medications more frequently. And because pain is so difficult to measure, it's very difficult for doctors to know how to properly prescribe pain. Right. But because they have a patient that they say is in pain, you can't necessarily neglect that.
Sure.
You have to work with that.
Yeah, not to mention there's racial, ethnic, and gender differences in how pain manifests, not just manifests, but how people think about pain in different populations. So people can come into the same examination room and just have a different characteristic, be a woman versus being a man, and the physician interacting with them will make assumptions about how much pain they might be in or what they need. Yeah.
Tolerance especially.
So one person who needed 20 pills, let's just use that example, might put them down when the problem goes away, and then another person might not. Why do different people react differently? Why does one make that jump to abuse and maybe the other doesn't?
Sure, I think it's a difficult question. It's very individual. I think part of it is individual susceptibility, underlying genetics, family history, and things like that make everyone function differently. So it's that environmental interaction as well.
Yeah, and I think for a lot of people, they don't see it as abuse. They see it as, they just continue on this line where they are, in their heads, they're treating themselves for pain, and their treatment, they build a tolerance, and so they need more pills to treat their pain, and so it gradually builds up. But a lot of people don't see themselves as addicts until much further down the road, until they're like, well, my use is out of control. I'm taking so many pills a day. something's wrong. And then if you stop them, we have lots of people who their doctor will think they're taking too many pills and cut them off. Well, then they go into withdrawals and they go to the streets to get pills in order just to keep from feeling terrible from those withdrawals.
It's so debilitating, and then they're thinking about the cost of it as well, and then people start to go into other drugs like heroin that are cheaper than prescription drugs.
They are cheaper.
And that obviously wreck your body.
Right.
You said, okay, so doctors get 7 hours of this kind of training. Who else should be getting training, or should anyone else be kind of in the loop there when it comes to education of this problem?
Well, I think that pharmaceutical companies have some responsibility in terms of training people on the medications that they have available. But I think doctors, in terms of also with the education, there's also this fear of if I overprescribed, I could be investigated by the DEA, or if I underprescribe, am I really treating my patients? And so there's education, but there's also the fact that pain is so hard to measure, as we brought up earlier, that there really doesn't seem to be a very good solution. We have these PMP programs that are used to track how much someone's being prescribed, and it's supposed to curb doctor shopping, but in the state of Missouri, we're the only state in the entire country that doesn't have a PMP program.
That's excellent foreshadowing. We're going to talk more about that later in the show. One thing I want to talk to you about real quick, though, is we started out the conversation talking about the youth. I remember the DARE program.
Yeah, sure.
So did that help? Is that still going on?
It's interesting. Everyone knows about DARE. It was pretty much ubiquitous. Everyone knows about DARE.
Great publicity.
Right. But as far as we know, the results are pretty inconclusive. And we can think about a number of reasons why it didn't work. Were they reaching the right audience? Was the messaging right? So I think from a broader prevention standpoint, we have to think very carefully about what works. So we have some good models now of campaigns at national and certainly at local levels that have worked, like Truth Campaign around anti-smoking. So that was a campaign that they did a lot of market testing, market research, segmented the audience in a very savvy way. And we've seen some results in Truth Campaign reducing initiation of smoking.